Okay. On to the respiratory system, right? How we breathe. Very important. All right. So respiratory system, again, specialized for us to breathe, to bring oxygen into the body, to get rid of carbon dioxide. And bottom line, what we have to do is prepare that air and make sure that it's good for our lungs so we don't damage it. And then we have to get it to the whole rest of the system. And that's what the respiratory system does. It also does allow us to talk. It does help with our sense of smell. And believe it or not, it helps to regulate pH. And we'll talk about that again in more detail when we get to acid and bases. But yeah, it helps us regulate blood pH. So we have to learn some terms. And first of all, you can have these terms of respiration. It's exchanging of the gas between the atmosphere and the cells. Atmospheric pressure is important here, okay? And respiration refers to the way that we acquire energy. And we have these events. External respiration, basically that can be broken down into two things. First of all, ventilation. Think of, bottom line is bringing this air in. When you put somebody on a ventilator in the hospital, and that's bringing the air into the lungs, okay? And getting this exchange done. And then we have this internal respiration where we basically move this into the capillaries and take this to the cells and release it to the cells, which is internal respiration. And then cellular respiration, which is where we're going to make ATP. So we're going to go through each of these in that process. Now, in order to do this, we use the respiratory tracts. We have the upper respiratory tract, which is basically from here at the throat up, and then the lower respiratory tract down. And you can see the division. And, you know, we say, I have an upper respiratory infection. You know, I have a lower respiratory infection. But that is the division that we use. Okay, so you can take a look at that. All right, so starting at the nose, we have the nostrils, the external nares, which are the openings into the system, and we do have hairs there. We're going to be talking sweep and weep, all right? We have a nasal cavity, which is the space behind the nose, and we have these turbinate bones, these nasal conchi that basically as we breathe the air in, it starts to roll the air. And the reason for that is we have these mucous membranes, pseudostratified ciliated epithelium. Ever heard that before from AP1? But basically what we're going to do is sweep and weep. And what we're trying to do is by breathing in the air into the nose, we want to prepare the air for the lungs. We need to moisten it, we need to warm it, and we don't want to breathe any debris in, whatever it may be. All right, so the goblet cells are going to secrete the mucus to trap pathogens or dust or pollens. We have the cilia that is going to sweep mucus towards the pharynx. When you do that, and you swallow that mucus, that's what you've done. You've basically made a little packet for your body to swallow it down to the gut, and the gut's going to get rid of it for you. But that's what you're doing. You're trying to prepare this air. And so these pathogens and these particles are gotten rid of in the stomach, and that prevents infection. So we're going to warm, we're going to moisten, we're going to filter this air so that we have nice, good, warm, moist air for the lungs so they don't dry out or we hopefully don't get any infection. Okay. The sinuses are air-filled spaces. We have several of them. Basically, without these air-filled spaces, you wouldn't be able to hold up your head. So it does provide lift there. They do have mucous membranes and lining them, and helps us resonate the voice. We all know what happens, you know, when our sinuses get clogged, our voice totally changes. Sinusitis, affection of these, sinus pressure, headaches. Some of you guys have had it, but there are several different ones depending upon where you are in your head. Okay. All right. The pharynx we've already gone over. We've talked about the nasopharynx, oropharynx, laryngopharynx before, but this is just a passageway. We get down to the larynx, and this helps us move air in and out of that trachea. It is where the vocal cords are. We do have these cartilages. We do have the thyroid cartilage, which is the Adam's apple. This is the thyroid gland, covers the bottom part of that. We have a cricoid cartilage, which is below that, and then we have a cartilage, which is a central portion of the epiglottis. And you can take a look and see that. Okay? All right, so. Okay, so the larynx contains two vocal cords, two pairs of vocal cords. We have false vocal cords and we have true vocal cords. The false ones don't make any sound production. They just help close the airway during swallowing, whereas the true vocal cords are what allow us to make sounds and allow us to talk. Okay, and by vibrating them, that's how we make our sounds. And you can take a look at those. You can see these. There's a nice picture of them. All right, so let's get into the trachea, or the windpipe. All right, it is in front of, again, the esophagus. It enters into the thoracic cavity and splits into what we call the primary bronchi. And then the primary go into secondary bronchi, and the secondary bronchi go into tertiary bronchi, yes. This trachea is lined with C-rings of hyaline cartilage, and what this does is, again, prevent the collapse of the trachea as you suck in air. Think of a straw. If you suck on a straw, that straw can completely close down. You don't want that to occur. If you get a blockage in your airway, you can have a tracheostomy done, where we cut the opening in the trachea and insert a tube, and you know, hopefully you can be able to breathe. Okay, but you can see this down to the trachea, into the primary bronchi, into basically starting into the secondary, and so on. This makes a tree. You can see the tree, okay? And we call that the bronchial tree. And it branches and branches and branches, and you can see this primary, secondary, tertiary branches of bronchi. And then you go into the bronchioles, little bronchi, and then you go into the alveolar ducts, into the alveolar sacs, and finally into the alveoli of the lungs. And this is where the gas exchange actually occurs. All we're trying to do with the tree is just separate this out so that we have more airspace to exchange. So you can see that coming down in, and you have this air sac, this alveolus. Okay, and there is a cast of the bronchial tree that was actually made, and you can see it. All right, so functions of that alveoli. As I said, we're basically just transporting air down, and when we get to the alveoli, what we're trying to do is provide surface area. We have to have a lot of surface area for this gas exchange to occur. Only structures that contain alveoli can do the gas exchange. And it's done across a very, 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 very tiny membrane. During this gas exchange, O2 is going to diffuse from the sac into the blood capillary, and CO2 is going to be exchanged for it. All right, that's what we want to occur. So we're looking at this alveoli. There is the actual blood flow coming in here, venous side, because it's low in oxygen. This is actually an artery, but you can think of it this way. But this is an arterial. This is a venule. Again, pulmonary circulation, opposite everything else. So this is the artery coming in, the pulmonary artery coming in, and the O2 is low, the CO2 is high. We're going to talk about this, and it just moves by diffusion. And then we're going to pick up oxygen and off gas, and by the time you go out the pulmonary vein, you're high in oxygen and low in CO2. You can see that picture. All right, so the lungs, very spongy. The right lung has 3 lobes, the left lung has 2. We've got to have room for the heart. If you're talking about a cat or a pig, there are 7 lobes. All right, just FYI, there is superior, middle, inferior, and a mediastinal under the heart. You do have a membrane covering these lungs. Where have we heard this before? I mentioned this when we were talking about pericardium, and I said that you have a visceral and a parietal membrane, and then the cavity in between, that has a fluid. So visceral is attached to the surface of the organ. So we had visceral pericardium. Now we have visceral pleura for the lungs. We have parietal pleura, which is that outer layer that lines the thoracic cavity. And in between, we have pleural fluid in the pleural cavity. Okay, so same prefixes, same wording, just we're exchanging pericardium with pleura for the lungs, okay? And you can see that. All right, so ventilation, moving this air out of the body into the tree and the alveoli. And so this entails inspiration and expiration, and one complete cycle is a respiratory cycle. And this is based on some physics, okay? Sea level, we have atmospheric pressure at 760 millimeters or 1012 millibars, whichever you want to go. But the respiratory muscles are at rest, and the atmospheric pressure, the pressure here and the pressure in the lungs are the same, okay? And that's an important thing, because what we have to do is we have to create a vacuum, if you will, to get the air to flow into the lungs, all right? So what we have to think about is Boyle's law, which says the pressure and the volume of the gases are inversely proportional. Therefore, if the pressure inside the alveoli decreases, atmospheric pressure pushes the air into the airways. Think of it as diffusion of air. You go from an area of higher pressure to an area of lower pressure. Now, what we have to do that, the way we have to do is change the volume of the thoracic cavity. All right? And so when we drop the diaphragm and expand the rib cage, that volume increases. And that decreases the pressure in the lungs down. Yeah, 758, you guys can read. But that's enough of a decrease in pressure to allow the air to go from your mouth into your lungs. All All right, so air goes into the cavity. All right, and you can see this. And then it's an active process. You have to expand the chest. So at rest, the atmospheric pressure and what we call the intrapulmonary pressure are equal, and there is no airflow. So if you just sit here and just open your mouth, not breathing in or out, there's no air exchange. In order for air to go in your lungs, you have to expand the chest and drop the diaphragm. Otherwise, nothing happens, okay? And so when you inspire, the thoracic cavity expands. It expands laterally, expands vertically. We drop the diaphragm, and that drops that pressure in that lungs, and the air goes in. When we exhale, it's exactly the opposite. The cavity contracts, which now raises the pressure in this cavity, and we breathe out. Simple thing, okay? Now, normal inspiration, we're going to use the diaphragm, and we're going to use those external intercostal muscles to enlarge that cavity. We know where these are, all right? The one thing that we have to think about is we have a protein called surfactant that allows us to reduce the surface tension in the alveoli, which allows the lungs to expand. I'm going to my hand a little bit here, my drink. And I'm going to rub the hands together a little bit. Need a little more. But surfactant, water has a high surface tension. And so when you breathe out these, I don't know if you can hear it. So you hear that stickiness? So when you have a fluid, it has a tendency to stick together because of the surface tension of the water. What surfactant does is lay over that moisture and reduces the surface tension, so it makes it easier for your lungs to expand, okay, to get away from each other. Otherwise, they would collapse down, and it would take a lot of force to open the airways. We'll talk about this, but this is what happens with infants when they have immature lung disease. And luckily, we have surfactant, artificial surfactant we can give them. All right, when we do a forced deep inspiration, that requires contraction of other muscles. And you can see the scalenes, the pectoralis minors, the sternocleidomastoid to do that, okay? So you can take a look at that. All right. Now, normal expiration, we're going to have elastic recoil of the tissues, and the abdomen occurs, and they just return to their original shape. And again, that surface tension develops on that surface, and hopefully, we got enough surfactant to overcome that. And expiration is a passive process. It doesn't take any energy. All right. We can do a forced expiration. We can contract the internal intercostals, abdominal muscles, and just add a little more force and do a kind of motion. Okay. Now we can measure these things. If you're having some kind of lung disease, or maybe we used to do this with patients before lung surgeries, just that, the anesthesiologist would want to know, how well are the lungs working. So we can actually look at respiratory volumes. We can do this spirometry to see what these volumes are. The spirometer is a machine that measures these volumes, and spirometry is a measurement of these. And what it does is it tells us how much capacity, how well is this air moving, okay? You have three main ones. Tidal volume, which is just the normal breathing in and breathing out. Breathe in, breathe out. Tidal volume, okay? We have an inspiratory reserve volume. We have an expiratory reserve volume, the stuff that's left in there. And we have this residual volume that we can't measure. There's always some air left in your lungs. You can't completely blow out everything, okay? But what we want to know is what's called the vital capacity. And the vital capacity varies, but vital capacity is the amount of air that we exchange with a forced inspiration and a forced exhalation. So you try and breathe in as much as you can and breathe it out as fast as you can. And that is your vital capacity. And that, again, emphysema, pneumonia, asthma, lung cancer, something like that it'd be helpful to know those kinds of things. And you can look at these amounts. But you can see the tidal volume, the normal breathing in, breathing out, we exchange about 500 mLs. The total lung capacity is about 5.8 milliliters. Very close to, heart circulation. We said 5 to 6 liters? Think about that. So you can sit there and see these capacities. There is a dead air space. You can't, again, breathe it all out. So you have anatomic dead air space. This is the air in the respiratory tract that remains, that didn't reach the alveoli. Then you have the alveolar dead space there that reached non-functional alveoli or something like that, or maybe there's some poor blood flow or something like that. And then you have the physiological dead space, which are the two combined. And so we leave about 150 mLs in the system with each breath out. Okay. There are some non-respiratory movements, clearing the air passages, coughing, sneezing, laughing, crying, and so on. So just FYI. All right, some diseases, disorders that can decrease the ventilation. Asthma. This is where you get mucus secreted on the inside of these airways and they thicken. And usually this is an allergic reaction to certain things that you're, again, pollens and that sort of thing. Dog dander, cat dander, whatever it may be, but it's an allergen and it irritates these muscles and it leads to bronchoconstriction and wheezing. Okay, if you've ever had an asthma attack, you know what that is. Emphysema is a progressive disease. It's degenerative. The alveolar walls are beginning to be destroyed, which decreases the surface area we have for gas exchange. It requires a lot of muscular effort to breathe, especially sometimes to get it out. It is a type of COPD and is difficult. All right, so how we control breathing, we have respiratory centers. It is a normal rhythmic and voluntary act. Luckily, it continues when we're unconscious. We don't have to think about it. And our main respiratory areas are in the medulla. And we do have the rest, you can see that they set the basic rhythm. They set the activity. You have the pontine respiratory group that limits the duration of each inspiration. You can't overinflate your lungs. There is a stop to it. So if you do this exercise where you breathe in and don't breathe out and breathe in and don't breathe out and breathe in and don't breathe out, and then you can breathe, you can only get so much air in. You cannot overinflate your lungs because eventually what will happen is the atmospheric pressure differential equals and you can't do it. All right, so when we talk about the physics of gas, one of the important things that we have to think about is what we call the partial pressure of the gas. You have a mixture of gases, and in a mixture of gas, each gas contributes to its own pressure. And so each pressure that each gas contributes is called its partial pressure. And basically that's its concentration. So when we talk about partial pressure, we use a big P like this with the gas. All right, so this means the partial pressure of oxygen. Okay, so if we look at this, the partial pressure of oxygen, if we look at, hopefully you guys know this, nitrogen 79%, oxygen 21%. So oxygen is about 21% of our air. With an atmospheric pressure of 760, we times that, so about 160 millimeters of the total 760, that is the partial pressure of oxygen. And that is at sea level, if we're starting to talk about the partial pressure at 760. If the atmospheric pressure changes, these change, okay? So the type of factors that affect the rate and the depth of the breathing would be the partial pressure of oxygen, partial pressure of CO2. You go to Colorado, where it's 10, 12,000 feet, and you go skiing, it's harder to breathe unless you live there. And that is because the atmospheric pressure is lower, the partial pressure of oxygen is lower, and you need more effort to bring the oxygen in, okay? The other thing is your hydrogen ion concentration. Hemoglobin does not carry this oxygen as well in an acid environment. So we do not want an acid environment. We'll talk about that. Our ability to stretch this lung tissue. Do you have a lung disorder? Physical activity, if you are usually doing activities like singing or swimming, where you have to train, to take in air and hold it and expel it at a certain rate, those can affect the rate and depth of breathing. Usually the singers and the swimmers have a bigger lung capacity. You also have receptors, these mechanical receptors and chemoreceptors that are looking at, are we actually dilating vessels? What's our pH? We're monitoring them in the aorta, in our heart, in our spinal fluid at certain places. Are we getting enough oxygen? Are we getting rid of the CO2? What's the pH? The main controlling factors are looking at the PCO2 and the hydrogen ion concentration, which is the pH. Those are the two biggies. So we do have chemoreceptors. They are in the medulla. They monitor pH in the brain. Low blood PO2 doesn't have much effect on them. Hydrogen ions don't cross, again, the blood-brain barrier very well. But CO2 does, and it binds to water to make carbonic acid. And carbonic acid can dissociate into these hydrogen ions, and these ions are detected by these chemoreceptors. And so an increase in CO2 or an increase in hydrogen ions, i.e. decrease in pH, leads to increasing your alveolar ventilation. You want to start breathing deeper and better. Okay. So we do have these chemoreceptors, as I mentioned. They sense changes in PO2, and these are in the carotids and the aorta, because we want to know, the blood that's going out of the heart that we're pumping, what does it look like? So we're looking at that. Decreased PO2 causes an increase in breathing rate, increase in tidal volume, so you start breathing a little bit deeper and a little bit faster. It doesn't usually, as it says, cause a major response until the PO2 decreases to about half the normal value. But you do have it in, again, I mentioned this inflation reflex, the Herring-Brewer reflex, that prevents overinflation of the lungs during forced breathing. You just can't you just can't do it. You reach a point where you can't get any more in, so don't worry about it. Okay, so the gas exchange, alveoli is the site of this. You have these microscopic air sacs at the ends of the ducts, and these pores permit the air to pass from one alveolus to another. And you have, again, this is a huge portal of entry, so you're going to have macrophages, even though you've cleaned, you've swept, you've weeped and sweeped, it may not catch it all. So you do have macrophages in there to pick up whatever you may get. So you can see those pores in there. All right, so let's look at this respiratory membrane. This is the membrane across which this exchange occurs. This membrane is the entire membrane, which is made up of the endothelium of the sac, the part that touches the space, the outside of the blood vessel, and then the endothelium of the blood vessel. Basically, we'll go through this, but 5 different surfaces. That entire space is a half a micron thick. Now, that is tiny, so FYI. And it has to be tiny because we got to get this oxygen and CO2 exchanged. So most of this wall is made up of simple squamous epithelium, very thin. And so those are called the type 1 cells. The type 2 cells are in the wall of the alveolus, secrete the surfactant that we talked about. All right, so the gas exchange has to go across the alveolar wall, which is simple squamous epithelium, the blood capillary wall, which is simple squamous epithelium, and the basement membranes of these layers and the spaces. And again, that whole thing is a half a micron. So you can take a look at that. You can see, boom. So you've got this space, the lining of this, the space, the lining of this, the lining of that, until you finally make it into the red blood cell. So if you take a look at this, you can see this whole respiratory membrane. So again, half a micron thick. Very small. And you can see basically what happens is these RBCs line up, so then they get squeezed in this capillary, so it gives them more surface area. And this is why if they can't squeeze anymore, that spleen's going to remove them out because they're not going to be able to do their job. Okay, so when we look at the diffusion through this is diffusion. Diffusion is moving from an area of higher concentration to an area of lower concentration. Okay, so the gases will diffuse from an area of higher partial pressure to an area of lower partial pressure, because remember, everything is done individually by the gases. And so there's a few, again, these are a few factors here. Increased diffusion occurs where you have a greater surface area, where you have a shorter distance, when you have basically a steeper pressure gradient. And 2, there's something called gas solubility. Some gases are more soluble than others. Nitrogen happens to be very soluble. This is why we can get nitrogen narcosis. Decreased diffusion occurs when you have that decreased surface area. So we want that surface area to be there. If we have any harm to the respiratory membrane or something's going on, we're going to get decreased diffusion. So the driving force, as we said, for the diffusion is the difference in the partial pressures of the gases individually. And that's important to remember. So if we look across here, we have, this is the coming in on that arterial side from the pulmonary artery. And we have, look at the partial pressures. The PCO2, we said this is a deoxygenated blood at this point, okay? So this PCO2 is high at 45, the PO2 is low at 40, but what we have to look at is what's in the air, okay? Well, atmospheric air, 21% oxygen, so we talked about that partial pressure. Carbon dioxide is much lower. When you add the two, the carbon, the CO2, if you remember, it's a small percentage. It's growing up a little bit, but it's less than 5% of our in atmospheric air. So this is going to be low, and the PO2 is going to be high. This is higher than this number. This is higher than this number. So just by diffusion, as this comes in, you off-gas the CO2 and you in-gas the O2, so that by the time you get over here to where you're going out via your pulmonary vein to your heart, your CO2 is down a little bit, but look at that PO2. Big difference. You've moved this, okay? And that's what allows this to occur. So you can look at the different disorders that impair exchange. I think you can understand what is going on, but it makes it more difficult to exchange these gases. All right, so now once we've moved it into the capillary, we've got to transport it to the tissues. And the blood is going to transport it between the lungs and to the cells. And as the gases enter the blood, they will dissolve in the plasma or combine with something. All right, so oxygen, 98 to 99% of it will diffuse and enter the red blood cell and bind to the hemoglobin. And when that oxygen is bound to the iron, if you have 4 spaces in the hemoglobin, you can bind you can bind to 4 O2s, okay? So you can have 4 O2s. If all 4 bind, you have 100% saturation. So when we talk about your pulse ox and somebody says your O2 saturation is 96%, let's say, that means 96% of that hemoglobin has 4 oxygen bound, okay? That is fully bound. And that's why the lower that number goes, the worse it is, okay? All right. There's a tiny amount that dissolves in the plasma, and the factors that increase it, yeah. If you have a decrease in PO2, you're going to bind more. If you have an increase in PCO2, you're going to bind more. Again, if you have an increase in acidity, you're going to try and bind more. You want to bind more because it doesn't carry as well. If you have an increase in temperature, that means increase in metabolism rate, which means you need O2 to do the metabolism. We do aerobic metabolism. So if you have an increase in temperature, you're increasing your metabolism rate, which means you need the oxygen to do that. Okay? All right. Basically, blood is oxygen rich. We want it to be 100% saturated in the pulmonary capillaries. And so the differences cause that oxygen to diffuse from the blood into the fluid around the cells. And after we drop off the oxygen to the tissues, the hemoglobin still remains about 75% saturated in the venous blood. It is called oxygen poor blood or deoxygenated. And when you sit there and think about it, 75% is deoxygenated. This is why when people go down below 90, about 90% sats, we start thinking about putting O2 on them. Okay? All right. So the factors affecting this, the PCO2, as the PCO2 increases, the body compensates by releasing more oxygen. So the amount of oxygen that is released from the oxyhemoglobin increases. All right. So if you've got a high PCO2, we're gonna try and provide more oxygen. Again, the pH of the blood makes a difference as the acidity increases, as the H plus increases. The amount of oxygen released from oxyhemoglobin increases because it doesn't bind as well, and we have to provide more. All right. Okay. CO2, as we do cellular metabolism, we'll talk about it, the byproducts, we make carbon dioxide and water. So the CO2 will diffuse into the capillaries because the tissue has a higher PCO2 than the capillaries. CO2 is transported in a few different ways. It does dissolve in the plasma. It remains a carbon dioxide. It does form what's called carbonamine hemoglobin, can I talk today, which is where it binds to the hemoglobin in the red cell itself. Or it can be part of a bicarbonate ion, and this is where most of it is done. Bicarbonate is the result, and you can see the equation. CO2 plus water makes carbonic acid, which can be disassociated into hydrogen ions and bicarbonate. There we go. Okay. This we will see again because this is pH. We can go back and forth. Acid, base. Okay. So, there you go. All right. Some lifespan changes here. We get fewer epithelial cells. Those ciliated cells, we get fewer number. The cilia become less active. Mucus starts thickening. Your reflexes of swallowing and gagging slow down. Those that take care of the real elderly know that it's hard for them to swallow and they gag a lot. And you have to be careful how you feed them because of that. You have increased susceptibility to respiratory infections. Think about how many people the elderly die from pneumonia, okay, because they don't have that ability to expand their lungs. Breathing requires more effort. The costal cartilage stiffens, and basically most of them are lean over like that. That changes the shape of the thoracic cavity, makes it harder for them to breathe. Okay, and so forth. So that's it for the respiratory system, guys.